So today we'll just cover a quick study update, and then I'll pass over to Danny to discuss the trial background, the study trials, so the different interventions, and today's focus will be on eligibility, and a discussion around that. And then we'll open it up to discuss any specific site challenges that you might be having or any other queries. And then we've just got a quick update about some study documents that we've updated recently. So just to start on a positive note that we currently have 13 sites open to recruitment. Last month, we've had 3 sites open, so Derriford, Sunderland and Watford. So it's quite exciting to have all these trial teams join us. And we just wanted to give a big thank you to all of our participating sites that we currently have over 110 participants recruited to the trial to date. But we are still looking for more sites to join us. So if you are not yet part of the trial but interested in joining, we're still accepting expressions of interest. And our feasibility form can be completed online. So just get in touch if you'd like a copy of our feasibility form. And then I will just pass over to Danny to discuss this next section.
Greetings all, and it's lovely to see you, or at least join you online for a SepTiC catch up. So what I'm going to try and do is run through a brief reminder about the trial, but try and move through this fairly quickly till we get to the sort of nub of the conversation around eligibility and site challenges, and hopefully maybe hear from you. So SepTiC's trying to answer several questions. One being, does a molecular approach combined with a procalcitonin measurement improve antibiotic stewardship and therefore improve outcomes? Is conservative fluid therapy better compared to standard care? And then in an embedded sort of sub-study, does GCSF compared to placebo improve outcomes in a high-risk subset that we'll come back to? And then, as well as the clinical, we're also interested in the cost effectiveness of each of the interventions. So I'll jump to the next slide. So some brief rationale. Essentially, we know that if you get inadequate empirical antibiotics initially, you have a higher risk of death. However, in using very broad spectrum antibiotics to address that issues, we face the ever-increasing challenge of antimicrobial resistance. And we know that whenever we use molecular assays, that often treatment is changed. And that's led to a nice recommendation that we should consider using rapid molecular tests in combination with other biomarkers such as procalcitonin. And as many of you will be aware, we've recently completed the ADAPT sepsis trial that will be presented at Critical Care Down Under. So we'll understand the role of procalcitonin, but we further need to understand how procalcitonin acts in addition to these novel molecular assays. That's the antimicrobial resistance approach or stewardship approach. This is work that John Silversides undertook, and essentially the take-home message from this is that in critically ill patients with sepsis or ARDS, the point estimate seems to favor a conservative approach with fluid management, both in terms of limiting fluid given, but also active deresuscitation. However, that isn't significant in terms of the sort of confidence interval crossing 1. So we need further evidence to support whether or not this is the right approach. We'll go to the next slide. And then finally, this is the embedded sub-study with GM-CSF, which is an immunostimulant in essence. And we know that people who are sick, they tend to have an allergic immune response, so their immunity is actually reduced after an initial excessive immune response. And that immune suppression leads to secondary infection and potentially death. And we hope that GM-CSF might stimulate immune function and improve outcomes. And again, you can see in this systematic review that the point estimate favors GM-CSF, but it's not conclusive. So hence why we need a large definitive trial like SepTiC. So go to the next slide. So as you will all know, SepTiC's essentially a large, pragmatic, multifactorial, open label, randomized controlled trial with an embedded randomized double-blind parallel group trial of GM-CSF. Jump to the next slide. And this is just an overview, but I will maybe just in the next slide look at this in a bit more detail. So essentially, we want all ICU patients assessed for eligibility, and those that are admitted with suspected sepsis and expected to stay for a couple of days are then randomized if they do not meet any exclusion criteria. This is an ambitious study. So you've heard we've recruited 110. So that means we've only got about another 3,500 patients to go. So we do need every bit of help. And you can see then patients are randomized to receive PCR and PCT versus standard, and conservative versus standard fluid regime. So each patient is randomized into both of those arms by default. So you can see the sort of multifactorial design. Then if we jump to the next slide, we can see then in a subset of patients who are receiving mechanical ventilation or have multi-organ support with pressors or renal replacement therapy, and who have a surrogate for immunosuppression. So that's lymphopenia less than 1.2 on 2 consecutive days. And we're going to recruit approximately 1,300 of that overall population to GM-CSF or placebo. And you can see that the primary outcome and secondary outcomes are listed here, but the primary outcome is 90-day all-cause mortality and clinical state, which is quite an interesting outcome that I'll come back to in a subsequent slide. So we'll jump. So these, just to remind you, are the inclusion criteria. So adults greater than 16 admitted with suspected sepsis and expected to stay in ICU at least 2 days. And again, we're not prescriptive in terms of the definition of sepsis. It is essentially acute organ dysfunction associated with suspected infection, but we don't actually define what organ dysfunction is particularly. So that could be anything from high flow, non-invasive, pressors, renal replacement. So there's no strict definition given the pragmatic design. You have to be receiving intravenous antibiotics for suspected sepsis, and according to the local clinician, there's initial adequate early fluid resuscitation. And this often presents some challenges. And people ask, do you need to give the 20 mils per kilo that's recommended in surviving sepsis, or how long should that be? What's initial? And essentially, this is really at the discretion. We want people to be adequately filled. So, it's really in that first 6-hour period, we're not starting deresuscitation or limiting fluid administration. So really, whenever we think about the early period, it's that very early 6-hour period that we're thinking about in terms of that early resuscitation. So we jump to the next. And then there's a range of exclusions that are listed here, and we'll talk about those in a bit more detail in the subsequent slide. But I guess just to emphasize, well, just to emphasize a couple. So not expected to survive 90 days. That's related to pre-existing chronic disease. And again, if we think about it, if we really believed a patient wasn't going to survive 90 days due to their pre-existing chronic disease, would they actually be admitted to critical care? There might be some occasions that might be true, but it would be very rare. So we don't expect to see many people excluded for this reason. It's very different from their acute illness and their acute severity. And then there's a couple of other exclusions which have sort of been combined, but just to emphasize they should be separate. So one is a source of infection that requires prolonged course of antibiotics. And they're pretty specific. So it's endocarditis, osteomyelitis, abscesses, and TB. So again, we don't expect to see a lot of those excluded. And we'll maybe pick that up subsequently. And then that second group of exclusions, DKA, hyperosmolar hyperglycemic coma, DI, and subarachnoid, really relate to more the risk of fluid deresuscitation. So those two things are separate. And if we jump to the next slide. And then for the GM-CSF subset, again, as I mentioned, it's either people on invasive ventilation or receiving two organ support, vasopressors or renal replacement. And indeed, if you weren't mechanically ventilated but were receiving high flow or NIV and one of these other forms of organ support, that would also count as well. And then if you have a absolute lymphocyte count less than 1.2 for 2 consecutive days, you would be eligible for the GM-CSF trial. Now we go to the next. And these are just the exclusion criteria listed for the GM-CSF, which I'll not go through individually, but you'll hopefully all recognize these. We'll maybe jump to the next slide. So the primary outcome is 90-day mortality plus clinical state. So it's quite a novel outcome. It combines both the landmark mortality, but a longitudinal outcome of how well you are in terms of your disposition. And we'll come back to that in the next slide. And then you can see the range of secondary outcomes that are listed here, and they're all fairly standard for a sepsis trial funded by the HTA. So early measures of outcome, including antibiotic use, wanting to know about longer term outcomes, and also the health economic benefits. So just to jump to the primary outcome then in a bit more detail. And as mentioned, it combines this setting of, or this landmark mortality of 90 days, but also then looking at a longitudinal outcome of whether you're discharged from hospital, if you're still in hospital without support, in ICU with support, or if you've died. And we think that's important for several reasons. So it's important to patients, not only do they survive, but do they then get out of hospital quicker without organ support. It's also important for healthcare utilization. It's obviously people surviving is important, but if you're remaining a shorter time in hospital, as well as being a survivor, that's important for the sort of healthcare sort of infrastructure that we work within. But also it offers some methodological efficiencies as well. So there are multiple reasons why this outcome is beneficial across both patients, health services, and also methodologically. So we'll jump to the next slide. So this is just a summary of our ambitious target, over 3,700 patients to be recruited. And we're hoping to recruit those from at least 60 centres across 3 years. we really need your efforts to recruit at least 2 patients per month from each of your sites. We recognize that is not an insubstantial ask, but we hope that because of the sort of inclusion and exclusion criteria, it will be a relatively straightforward study to recruit to. We'll go to the next slide. So this is, I guess, the first slide that I want to spend a bit of time on and maybe bring others in from the various sites. And I'm just going to, hopefully I'll not pick on you, but I will ask people if we don't have any discussion. So we're seeing, again, this is a combination exclusion, which we probably need to separate going forward. But we're seeing about maybe 25 or so patients excluded because of endocarditis, osteomyelitis, abscess, and TB. And that seems quite a large number. So I guess it would be useful just to understand from people who are on the call, maybe to comment, are they always people with those chronic diseases that will need prolonged courses, or is it maybe at the outset people thinking somebody's very sick and they might need a long course because they've got a positive blood culture? So be interesting if anybody has any comments or questions on that. I might pick on people if we don't have any answers or any comments. So stick up your hand and be brave. Are we losing people for other reasons than those? Everybody's being very, very shy. So let's see if we have anybody from Imperial that wants, given we're such a big recruiting site. Are we finding any people being excluded in Imperial because of reasons other than those chronic infections? Nobody wants. Oh, here we go. May.
No, I mean, most of them have been, for example, patients who have presented and endocarditis is expected, or I should say suspected, and the plan is actually to go ahead and treat the patients as if they are definite endocarditis patients.
Okay, so that's a really good point, May. So I think if it's suspected, they would still be eligible. But if it's, but you made a really good point though. If it's suspected and the plan is to treat the patient on that suspicion, then they'd be excluded. So you often see people come in and there's some uncertainty, maybe endocarditis or osteomyelitis is in the differential, and that's being investigated. That's different from a plan at the outset to say, I don't think I'm ever going to be able to prove if this is osteomyelitis or endocarditis, but we're going to treat them for that period. So suspected is okay to include, suspected, and a plan to treat as if they have that condition is excluded for sure. So there's a bit of a subtlety there. So that's a good point. More than 24 hours from admission, and that doesn't apply to GMCSF. It's got up to 5 days. But again, appreciating that it's difficult to do 24-hour recruitment. We're keen to see that come down. And let's see. So I'm just picking up a bit of chat. Yeah, so I think in that setting, so that's Naomi. I think where there is something like necrotizing pancreatitis, where certainly antibiotics are often needed. Again, unless it's confirmed at the outset that patients are definitely going to have, at least 3 weeks, I would include a patient like that. And the rationale for that is twofold. The evidence even for antibiotics and necrotizing pancreatitis is actually relatively limited. I mean, it is a position statement that you should treat, but it's not based on strong evidence. And again, we may see of use of antibiotics safely in that population. So for necrotitis and pancreatitis, again, you know, if it was going to be a 2-week course, I would go ahead and recruit. And the reason for saying that is if this intervention worked, it's likely to be applied to that population in the future. And therefore, we want to make sure we've got a generalizable and representative population. So, Naomi, thanks for that point in the chat. So more than 24 hours, as I mentioned, is hard. I guess it would be useful to think of ways in which it was possible to recruit early. I mean, I guess staffing is difficult, but you know, whether it's possible to get some local trainees trained to do the initial recruitment and consent. So we're keen. I know it's very difficult to get that down to 0, but we are keen to try if possible. We've talked about pre-existing chronic disease. So again, you know, to see 16 patients out of the ones that we've recruited so far, that's quite a lot. As I mentioned, you know, we wouldn't really expect people who were unlikely to survive 90 days from their chronic disease typically to be admitted. So remember, that's chronic disease. I don't know if anyone wants to make any comments on that. Maybe that's clear. I don't see any hands going up. We then have people not expected to stay. And again, it's often worthwhile with those last two. I'd be keen if you just locally look at how those patients do. So you may find that, you know, the patients you think that aren't going to survive 90 days actually do, and that people who are only expected to stay 1 or 2 days actually stay longer. So one of the sort of quality improvement pieces that you can do locally is just keep a list of those patients that you're excluding, and then just, you know, sense check that the decisions that are being made actually are validated, and that you're not getting those estimates wrong, because it's often very difficult to predict. The other group that we thought was worthwhile picking up on, and maybe we can see if there's anyone here. So refusal by the consultant or clinical team is always somewhat challenging. You're sort of being somewhat, you know, taking the autonomy from the family in that setting. And clearly, you know, a clinician may feel that there is significant risk that can't be quantified by the eligibility criteria. You know, whenever we did the RADAR 2 study that informed the resuscitation, you know, some of our consultant team were you know, cautious about the intervention, particularly in the neuro patients that we looked after. So I guess, would anyone like to give examples of where the consultant and clinical team felt it was appropriate to exclude the patient? Any takers? Have to pick on, here we go, Jessica.
Hi, Danny. Yeah, for us, we excluded one for consultant refusal because he normally treats septic patients quite conservatively anyway. So he felt that he didn't want to put them in, because what he'd done already, he felt like he'd sort of been really conservative in his management and started early inotropes.
That is interesting, and I guess a couple of things would spring to mind. We would hope that sites would have equipoise as they sign up. Now, I completely appreciate that getting a whole bunch of consultants to agree to one thing is by no means easy, because that's what happens at our place as well. So I understand, but I guess we don't yet know that conservative is the right answer. It might be based on the data that we have, but I would sort of it would be useful to appeal to the sort of team to make the case that this is the only way to know for sure. Indeed, and we don't believe this, but in radar 2, there were some signals where the point estimate went for harm with conservative therapy in a subgroup of patients. So there's just so much uncertainty. So I guess I would encourage, where possible, everyone to recruit because we really don't know the answer. But that's a good example. Any other? Thanks, Jessica, for that. Any other examples where people were excluded? Chloe.
Hello, can you hear me?
We can.
Oh, lovely. Sorry, I'm having an absolute nightmare with my headphones. I'm not entirely sure if the last person who spoke raised the same issue. Sorry, because my headphones cut out. But with the consultant or clinical team refusing to enroll, initially we had a lot of reservations about the conservative fluid management potential, and it took us a lot of educating, especially when the medical team would switch over. And they had a lot of reservations about implementing that. So we had to really point out whether they fit the criteria for hypovolemia, that we could treat them for that. So education really was the key there.
So Chloe, that's a really brilliant point, because in fact it's the exact opposite of what Jessica's clinical consultant said, that they had decided that the conservative was the answer and weren't prepared to randomize to liberal, which just shows the huge uncertainty. And sorry, I've just been sorry, 1 second. Sorry about that. So, I mean, it just shows the uncertainty of both approaches. So I guess we need to encourage people just to randomize. I think that's the key piece. And Chloe, I think your point is that really important in terms of the conservative piece, that we need to reassure that there is an eject option if there is signs of hypovolemia, so that we don't cause any harm. So that really good points. So let's see. I think those other ones we can probably leave. Well, maybe just before we, I think, jump on to the next slide, which is about co-enrollment, and maybe just pause here and just ask sites for any other barriers or challenges or anything else that sites have experienced. I'm happy to run through site by site, or if people want to raise their hands. I mean, I know I see Catherine's joined us from our own site, and our major barrier is getting governance approval. So we are not even at a point where we can start recruiting. But I guess for those sites that are open to recruitment, have you identified any specific barriers? As Chloe highlighted, is there a need for any additional educational material? So it'd be really helpful to hear a bit of your feedback. Or not. Be brave. Okay, you're stunning silence. So you're not having any other. Oh, here we go. Yes is the answer to that, and we do most of our eligibility remotely. So again, Charlotte, it depends a wee bit on your healthcare setup. So if you've got an electronic patient care record, it's absolutely fine for somebody to review the eligibility on that remotely, and we do that all of the time, as long as it's documented that someone who's medically qualified and on the delegation log has confirmed medical assessment of eligibility, then remote confirmation is absolutely fine. Thanks for that. Any other questions? If people don't want to speak up, you're very welcome to put something in the chat. Chloe, go ahead.
Sorry, I'd like to backtrack just a little bit, please, and ask about the screening failure for a source of infection that will require a prolonged course of antibiotics for more than 21 days. Does this include patients who have maybe being treated for a long-term infection that they're dealing with either in the community or on the wards, like maybe a PICC line infection, and they've been on antibiotics, maybe a few different types, different courses, and then they finally come up to ICU? Would that also fit into that category?
That's a really good question. In fact, one that I meant to say, and before I forget, so that also doesn't exclude people on long-term antibiotics for post-splenectomy prophylaxis. So if you're on long-term antibiotics for that, you're not excluded. In terms of the situation that you've just asked about, so it depends a wee bit. If the deterioration is felt to be related to the indication for which they're receiving long-term antibiotics. So this is, somebody's been on antibiotics for a PICC line infection, and that's progressively getting worse, and they come into ICU and they get their antibiotics escalated for that, with an expectation that they'll be continued on long-term antibiotics for a PICC infection, then they would be excluded. But often what we see is people are on pre-existing long-term antibiotics using the PICC line example, as you say, but then they deteriorate with a secondary infection, and that's the common scenario because of this immunosuppressed state, and then they end up on antibiotics for perhaps nosocomial pneumonia. Those patients would be eligible because the expectation is that they would be de-escalated to their usual care, which would be long-term antibiotics for a PICC line or prophylactic antibiotics. So that one's a bit subtle, but yes, they wouldn't automatically be excluded. Brilliant question. Any other questions? Okay, so if that's all we have, we'll maybe move on to the next slide, which I think is on co-enrollment. Maybe it is good. So just to remind, we have a very liberal approach to co-enrollment where at all possible. As you can see here, we have co-enrollment agreements in with all observational trials, and then the trials that are listed here. And you can see that many of our trials that we're doing now often have multiple interventions. So you can see REMAP-CAP has some interventions that are included, but some that aren't. Likewise, Infinite is looking at another immunostimulant, so interferon. So we wouldn't want people in the interferon and the GM-CSF arms, but they could be in the de-resuscitation and the de-escalation of antibiotics. And then in terms of shorter, for example, we're trying to sequence those to allow co-enrollment. So as much as possible, we do allow co-enrollment. There are some studies where we can't co-enroll, and they're listed here, and that's usually because of biological interaction. So that's the sort of main reason. Some situations where we've got pharma studies, such as Tilia, there's a reluctance on the part of pharma to co-enroll, and that's a challenge. But where possible, we're keen to co-enroll. If you have a study at your site that isn't on the website, which holds the most up-to-date list, do let the team know, and we'll progress co-enrollment where at all possible. And we can usually get agreement pretty quickly. So even if you're screening someone who you find at short notices in another study, do let the team know, and we'll see if we can get that resolved quickly, even electronically between the CIs, pending getting agreements put in place. Good. So before we jump back to Ravi and the team to go over updated study documents. Are there any other questions or queries that people would like to ask me? And if not, then I will hand you back to Ravi.
Thanks, Danny. Yeah, if anyone, while I'm just going through the study updates, the study documents, if anyone does have any questions for Danny, please pop them in the chat and we can come back to it at the end. So, So we just had a couple of study documents have been updated recently. Our sites that are open to recruitment will have seen these, I think, on the newsletter that was sent around earlier this week, but we thought it doesn't hurt to mention it again. So we've finally updated our sample manual with the new address for our central lab. We also have new sample shipping boxes. So here's some images here. We were previously using the Royal Mail safe boxes, but as we are using our own labels, it just makes sense to change the boxes. So in the meantime, please do use up the Royal Mail safe boxes that you do have. And when we send you some more kits in your next replenishment, you'll see these new boxes. And we've also included some more detailed guidance on labeling the tubes. So nothing has changed in terms of the actual blood tubes to collect or the schedule or anything like that. It's just more about where we're sending them and how we're sending them. And you can download the manual from our website, and I think it was circulated as well earlier this week. We've also updated our randomization guide. So this is just to say that we haven't changed the actual process for randomization, but as we raised in the previous webinar, some of our site teams are having few issues with getting the allocation to appear correctly. So we've had some extra guidance on from Open Clinica, which we've included in our guide, and we've also updated our randomization video. So we just advise having a watch or a read through of the manual, but the actual process hasn't changed. We're just asking everybody to wait a little bit longer before opening the randomization allocation page, and then hopefully the assignment will be populated there. We've also updated our study drug prescription chart, which is available on the website. And just a quick reminder to ensure that data entry is completed for your participants on Open Clinica, and please review queries regularly. When we send out our study newsletter, we also ask for the screening logs to be sent through monthly. So I think we've received all the screening logs now for last month. So thank you everyone for sending them through. And these are just a reminder for all the different ways to contact us. And again, all of our study documentation, answers to the FAQs, and the list of enrollment is all found on our website. Our videos can be found on our website and also on the YouTube channel. And so the next webinar will be on the 11th of November. This will be with Prof. Gordon and always with the SepTiC trial team. And it will just be a generic session, questions for the CI. So we'll just take another pause there and see if anyone has any questions about the trial for me or for Danny.
It's your last chance now, so go for it. Everyone's happy and going to be recruiting like mad. So whenever you're talking to Tony next month, we'll be able to show that you're all recruiting 2 patients per month, and it'll be down to this brilliant engaged webinar. All right, look, thank you all, and appreciate you all taking the time. Really appreciate all of the efforts that everyone's making, and hopefully we'll continue to get lots more recruits. Thanks all.
Thank you, everybody.